The most important part when you're dealing with a cholangiocarcinoma is to stage the tumor. The grading and the staging of a tumor is very, very much important. And grading is like the tumor is, well differentiated, moderately differentiated, or poorly differentiated. So when you grade these tumors, that means the prognosis of the disease can be predicted. Like if it's a well differentiated tumor, so it would have a better prognosis as compared to the poorly differentiated. So that is why it's important when you're trying to grade these tumors. Second, if you talk about the staging, that's actually to know the extent or to know the invasion of a specific disease. So when you are trying to stage, you start from normal cells and then you try to see the dysplastic changes, and you figure it out if the dysplastic changes are limited to the epithelium, or it has breached the mucosal layer, it's breached the submucosal layer, or it's in the adventitia, or you can say it's in the serosa. So that means if the tumor has already invaded the serosa by the time he's presenting to you, that means the tumor has already gone beyond the resectability, because those tumors which actually involving the serosa, then most of the time they are locally invaded much, and there's a possibility that they can be extended to the bile ducts, and a complicated surgery can be. They have already gone beyond T2 staging, and in the surgical process or the procedure would be a complicated one for that. And plus the cardiovascular status of the patient, the respiratory status of the patient, in general look of the patient, in general physiology of the patient is important to know. Now, if there is a normal gallbladder, and what happens if we talk about the pathophysiology behind this, there is a normal gallbladder, then the gallstone, maybe not only the gallstone, maybe possible there was a primary sclerosing cholangitis, or there was some other diseases. So the chronic inflammatory process, like the gallbladder stones and the chronic inflammatory reactions in the form of the cholelithiasis and multiple episodes of the biliary colic, and then some congenital diseases like the Caroli disease and a primary sclerosing cholangitis, they all actually lead to the chronic inflammatory processes. And then these chronic inflammatory processes then can lead to the fibrosis. Okay, so fibrosis can lead to the dysplastic changes, and this plastic changes then lead into the carcinoma in situ. Now, what do you mean by carcinoma in situ? That technically means that the carcinoma is not invading the basement membrane, or you can say that it's just above the epithelium. So it's only involving the epithelium. It has not gone through or invaded or breached the basement membrane. So it is TIS. If we talk about the stage of that tumor, it's TIS. That means carcinoma in situ, and T0, that means there is no evidence of carcinoma, and IS, that means carcinoma is in situ. And then there are invasive carcinomas, and we have classified when once the basement membrane is breached and the tumor has far gone beyond the lamina propria, then they're termed as invasive carcinomas. And then invasive carcinomas are further classified as T1, T2, T3, T4, and we also assess the status of nodes, and we also assess the status of distant metastasis. So that's how the staging is being done. There are various number of the staging systems which are being used, but most commonly when we talk about the GI tumors, or when we talk about the colon, pancreatic, intestinal, and the biliary cancers, most of the time the staging system we use is a TNM staging system. And so the T means that the tumor, like the location of the tumor, okay? The carcinoma is in the epithelium, it's in the lamina propria, mucosa, submucosa, muscularis, or serosa. And then the N is for the nodal status, like the perihilar lymph nodes, or you can say the nodal status like the parietic lymph nodes. Distant nodal statuses, they are not. So you try to identify the nodal status, because nodal status, we know that those tumors who have far metastasized to the lymph nodes, so that means that they're better responsive to the radiotherapy. And sometimes if the the lymph nodes in a close proximity are involved, so that you can actually do the lymphadenectomy. And then there are some metastatic tumors, and by the time they present to you, they have already metastasized to the different organs, maybe to the superior mesenteric, maybe to the colon, maybe to the aorta, to the portal vein, and maybe they are metastasized to the liver or lung. And that's how the grading and the staging is very much important. So by grading, we means that the tumor, the morphological changes in the tumor, like the tumor is well differentiated, the tumor is moderately differentiated, or tumor is poorly differentiated. So the well differentiated tumors, they have a better prognosis. And poorly differentiated tumors, they have very, very bad prognosis no matter what you do, and ultimately you have to put the patient in a chemotherapy and a radiotherapy and a palliative treatment. So remember the sequence of the event. There was a normal gallbladder, then there was a formation of the stones, and then there were chronic inflammatory reactions, and then there were dysplastic changes. And because of the recurrent fibrosis and the dysplastic changes, then a full-blown carcinoma was developed, which was carcinoma in situ if it hasn't breach the epithelium, or the tumor is not extending beyond the lamina propria, and then you have the invasive cancers. Okay, another thing regarding the TNM staging, we already discussed about the tumor node and metastatic the staging system. So this TNM staging is widely accepted. So in a stage 1 tumors, like that is a carcinoma in situ, and stage 2 tumors, that means that there is mucosal or muscular invasion. Now, what do you mean by mucosal or muscular invasion then? So that means that the tumor has invaded the mucosa and up to the lamina propria, or there is some kind of muscularis invasion. And then stage 3 tumors, in which the tumor has already invaded to the serosa, and then there is a direct you can say a local spread or local invasion to the liver. And stage 4, there is lymph nodal metastasis, and the tumor is already beyond the serosa, and it's involving the adjacent structures like superior mesenteric artery, hepatic artery, portal vein, and then you have the stage 5 tumors in which a distant metastasis. This classification system is a little bit different as compared to T1, T2, T3. So actually on the basis of T1, T2, T3, T4, you stage this as a form of T1, T2. You also combine it with the lymph nodal status, and you combine it with the other distant metastatic status. So T0, that means there's no tumor visible. IS, that means the tumor is in situ, and T1 is the tumor which is involving the muscularis and mucosa and the lamina propria. But stage 2 tumors are the tumors which have already invaded the muscularis layer. So there are 4 important layers. The most important internal layer is mucosa, then you have submucosa, then you have muscularis mucosa, and then you have the serosa. Okay, so the mucosa is already being comprised of 3 layers. One is epithelium, the second is lamina propria, and then third is a muscularis propria. So if the tumor is already invaded muscularis propria, it's a stage 2 tumor, and then stage 3 are the one in which the tumor is in a submucosa and in a serosa. And if we talk about the T4 staging, that means the tumor is already engulfed to the adjacent organs, and a T4 and a T5 tumor is when we talk about the location, that means the tumor has already gone beyond that, and there is a reasonable distant metastasis. You can do the staging on the basis of CT can help you for that, and some other investigations like magnetic resonance imaging. And the most important is a PET scan, which is positron emission tomographic scan, and endoscopic ultrasound. So these endoscopic ultrasound are very, very much important, and they're very helpful in localizing, or you can say in staging the tumor. So preoperatively, when you are encountered with such a case in which a palpable gallbladder mass is there, then you can actually go for you have to identify the location, if it's the fundus and the body or the neck of the tumor, and then you have to grade it by the help of a biopsy. And if the biopsy is not available, then you can just go for a staging system, and you can just follow the staging system and try to seek the help of CT, MRI, PET scan, or endoscopic ultrasound can actually be very, very useful when you're trying to stage the tumor.